Okay, good morning, everyone. Let's start today's lesson. Today I'll talk about kinematic alignment taught on arthroplasty. So step by step. So kinematic alignment technology is now getting major. So this philosophy or strategy is very quite straightforward. Just cut the bone in the same thickness component. That's all. So the purpose of this technique is restore the patient pre-disease articular surface. This one, the same, uh, c- cut the bone in the same thickness as components. Normally, the distal cutting thickness is 9 millimeter, and the posterior is as well. Sometimes posterior component thickness is 8 millimeter, sometimes 10 millimeter, 9 millimeter. Just cut in the same thickness as component. But at that time, we should consider the bone at cartilage wear. In the medial side OA, medial cartilage is already worn. So cut the medial size 2 millimeter thinner than involved articular surface in the medial side OA. As a result, cut the bone 9 millimeter for lateral and 7 millimeter for medial. Regarding the tibial side, the thickness target is minimum thickness as components. Normally 10 millimeter, sometimes 9 millimeter is the thinnest bearing and the tibial component thickness. So cut the tibia in the lateral side in 10 millimeter and medial side 8 millimeter. That is the standard. But sometimes we adjust the tibia cutting angle alignment a little bit smaller varus alignment because sometimes the tibia bone has the bone defect and native tibia slope is sometimes very extreme. So to avoid too much varus cut, I cut a slightly reduced varus angle. Preoperatively, we routinely take these imagings, weighted AP and lateral and Rosenberg and skyline and the valgus stress X-ray in 20 degrees flexion and scanogram, long-standing X-ray, and measure LDFA, MPTA, mechanical HA, posterior slope, JLCA, that is under stress, so-called stress JLCA, and calculate arithmetic HKA. Arithmetic HKA is calculated by MPTA minus LDFA. And stress HKA. Stress HKA is arithmetic HKA plus stress JLCA. These are uh, predicted postoperative alignment and CPAC classification. But basically, of course, we measure preoperatively these alignments, but uh, during the operation, we only consider about articular surface. That is quite different from mechanical alignment TK. In the mechanical alignment TK, the standard that we always consider about mechanical axis for femur line axis between femoral head center and knee center, and regarding the tibia, the knee center and the ankle center. But there, we cannot see these axes, the directory. They are virtual axes. On the other hand, in the kinematic alignment TKA, we can see everything. Articular surface and worn cartilage, we can see everything. So I believe kinematic alignment is more reliable and more reproducible. Like this, I'm sorry, this animation is not good. So this is the LDFA and JLCA and MPTA, and MPTA minus LDFA is arithmetic HKA. And JLCA is angle between femoral articular surface and the tibial articular surface. So we define the minus value as lateral open. In other words, let's do the valgus alignment is a minus value. And medial open, that is slightly overcorrected. That is plus JLCA. And JLCA plus arithmetic aHKA plus stress, JLCA under stress. That may express the postoperative alignment. If the contractures or cartilage were perfectly corrected. So these are prediction or so estimated postoperative alignment. That is very important because we are aiming for not a straight leg, but the patient native alignment, so-called constitutional alignment. That is the target of the kinematic alignment, TKA. The first is exposure. We always use under-vastus approach, max retaining approach. In summary, in this approach, we never cut the muscle fibers, but inside the only fascia and capsule. And firstly, cut the fascia over the vastus medial muscle and detach the muscle fibers from the surrounding fascia and retract laterally, and cut the capsule laterally under the vastus muscles. After the procedure, we try to repair the capsule and fascia as perfectly as possible. So the four seal or close the capsule as perfectly as possible, so-called water sealed, watertight. As a result, so blood bleeding never leak to the muscle. So if the blood leak to the muscle can be swollen. So that can prevent the postoperative mobility and postoperative flexion. So how to reduce the muscle swelling? This is very important to quicker recovery. Okay, the first one is a distal femoral cut. So distal femoral cut is, let's say we should cut the same thickness as component. So on the paddle, on the distal part, should be placed at the lateral cartilage articular surface, where cartilage still remain perfectly. On the other hand, the medial side, in the patient with the indication of TKA, virtually most patient has the worn cartilage, no cartilage on the medial side. So we need 2 millimeter space between the paddle and articular surface because in average cartilage thickness is 2 millimeter. But sometimes this thickness is sometimes 2.5 or sometimes 1 millimeter. So most precisely, we should calculate the thickness of lateral cartilage uh, using the special tool. But roughly, we can estimate the cartilage thickness as 2 millimeter. And medial side is to compensate to 2 millimeter cartilage where cut the bone 7 millimeter. So how to adjust this one? Normally, in most instrument has the angular adjustment. So adjust the angle to the 759 and find the good alignment that makes the lateral is 9 millimeter and the medial side is the 2 millimeter space. Or if it is even difficult to make this entry hole of IM rod to be wider, the wider medially, laterally to be wider, and then you can adjust the exchange, no, sorry, bars and valgus alignment of the intermediate rod. Then find this space, this angle to be making a space for 2 millimeter in the medial side. But actually, this is very difficult. To more easier way is find the 2 millimeter shim metal plate and put the medial articular surface and place the paddle on the directly articular surface. For the lateral side and the medial side is put the metal surface. Or in some instrument set, we have stepped paddle, or that is already have the 2 millimeter space for the one cartridge side to just push this one on the articular surface. That's all. So, but purpose of this cutting cutting tool, just cut lateral side 9, cut the medial side 2 millimeter, 7 millimeter. That's all. Sometimes some patient still have very thin residual cartilage on the medial side. In this case, we always shape the cartilage out from the surface of the bone. Then expose the subcontraral bone and put the 2 millimeter seam or stepper paddle to the medial side. Oh, that's a quite important step. In the same time, after that, you should put a cutting block on this paddle. But at that time, every time you should make sure that both sides, both paddles, are touching on the medial and lateral articular surface. Sometimes this paddle can be off the bone during the further steps. So every time before bone cuts, you should make sure the paddle are placed exactly placed on the articular surface. After that, so connect this cutting block like this. And after that, I always use these variable stylus to make sure the cutting thickness is correct or not. So just this stylus to be 9 millimeter for lateral and 7 millimeter to medial. If you don't have these devices, you should use the angel wing and estimate the cutting thickness visually. So, in summary, so bone cut thickness very important for kinematic alignment, especially for Calipered kinematic alignment technique. So very simple. the cut the bone in the same thickness component. Okay, tomorrow I will talk about the further steps. Thank you for watching.